Good morning, everyone, or afternoon, depending upon your time zone. I want to welcome you to Virginia Garcia's 2023 Healthcare Symposium, The Future of Healthcare, Restoring and Rebuilding the Workforce. My name is Gil Munoz. I'm the CEO of Virginia Garcia Memorial Health Center, and I'm excited to welcome you all to this year's event. Each spring over the last 14 years, Virginia Garcia has brought together healthcare and community leaders from across the region to discuss important topics in community health and primary care. Over the years, the symposium has focused on a range of issues, including the transformation of primary care in the patient-centered primary care home, use of teledentistry, and the impact of adverse childhood events and toxic stress on the health of our population. This year, we're delighted to have Dr. Luis Padilla, Associate Administrator for Health Workforce and the Director of the National Health Service Corps. This is also our third year of a virtual symposium, which has allowed us to invite colleagues from across the region to participate in this year's event. I want to particularly thank the Northwest Primary Care Association and their CEO, Bruce Gray, for partnering with Virginia Garcia on this year's symposium. The focus on healthcare workforce for this year's symposium is natural as we emerge from the last 3 years of responding to the COVID pandemic, which brought incredible levels of stress, uncertainty, and rapid change to the workforce. We're proud of how we responded during COVID with mass vaccinations, testing, education, etc., but it has also taken a toll on workforce with burnout, pressures of juggling childcare and work, and wage inflation creating a volatile labor market. Here at Virginia Garcia, we are creating strategies to address this situation and attract new staff. At the same time, we are focusing on developing new healthcare professionals through a grow our own approach. We're already beginning to see this pay off with cohort after cohort of new medical assistants and dental assistants going through the certification programs. We've made the investment in the infrastructure needed to sustain these training approaches with the addition of MA and DA and pharmacy tech trainers, preceptors, coordinators, and executive sponsors to ensure that the programs continue. We continue to secure vital funding to support these efforts, and our Health Center Board has established the Maria Laredo Workforce Development Fund, named from our recently retired COO of 43 years, Maria Laredo. Her passion for staff career development was an inspiration for many. The program has provided more than 40 staff members with over $150,000 in scholarships and tuition assistance in just the past year. All of it in support of their ongoing career development goals. We're also building innovative partnerships like the one with the Hillsborough School District that expose bilingual, bicultural students to careers in healthcare. These partnerships make it possible for high school students to enter the workforce immediately upon graduation as a medical assistant, removing barriers often experienced by this group of young people. This opportunity acts as an introduction into healthcare and can be an important stepping stone for those desiring further career development. Virginia Garcia will continue to expand this program to include other careers in other school districts in the coming months. The journey back to a place where we will once again be fully staffed and able to provide the access to care our patients need is a long one. Like most in this room, we are looking ahead to the future. Much like the care we provide, we will continue to take steps to remove the barriers that keep diverse individuals from working and pursuing a career in healthcare, while offering existing staff new ways to excel in the workforce. Our moderator today is a perfect example of exactly how this can be done, and she is an individual I admire a great deal. Raised right here in Hillsborough, Oregon, she was the child of migrant farm workers. She came to Virginia Garcia in 2000, and in 2008, she graduated top of her class from Pacific University with a degree in dental hygiene. Yadira Martinez currently oversees the dental hygiene program the dental sealant program, and all dental activities at our migrant seasonal farm worker summer program. She also maintains a hygiene practice in the clinics. She recently became only the 9th licensed dental therapist in the state of Oregon, further expanding the quality care she is able to provide for our patients. Yadira is a skilled clinician, a competent manager, but has become a leader in the organization and externally, serving on the Oregon Board of Dentistry, where she served 2 terms, including as president. We are not only honored to have Yadira as part of our organization for more than 20 years, but glad she is here today to help lead us in this very important discussion. Welcome, Yadira.
Thank you, Gil, for that wonderful introduction. I'm honored to be here today. Working at Virginia Garcia all these years has helped shape who I have become, has driven me to do and be more for the communities we serve. I am inspired daily by the work we do at Virginia Garcia. I'm the child of immigrant parents who came to this country to give me and my siblings a better life. They sacrificed everything so that we would have the opportunities they did not. I do not take their sacrifice lightly. It's my North Star and drives me to do and be more. As a mom, I understand how the decisions I make are reflected in what my children see as possible for their future. I have a responsibility to move my parents' vision forward in their lives. When I started at Virginia Garcia in 2000, I had no formal dental training. I was attracted to the organization, not only because of their mission, but because even all those years ago, they invest in their staff. Virginia Garcia understands that helping employees grow not only enriches their lives, but also that of their families and communities. I didn't know it back then, but when I was given the opportunity to grow, my family was inspired to follow. I was the first one in my family to earn a college degree. I was followed by my sister, and now my brother is working on his master's degree. All of that happened because Virginia Garcia decided to invest in me. When I started at Pacific University, there weren't many people who looked like me. When I started at the Oregon Board of Dentistry, there weren't many who looked like me. It is my aim to normalize people like me in these spaces and help lead the way so that others can see what is possible. For more than 20 years, Virginia Garcia has provided me with a place that encourages and supports growth and inspires innovation. It is only because of this that I have been able to continue growing in my career. With the help of the Maria Laredo Workforce Development Program, I recently became one of only 13 licensed dental therapists in the state of Oregon. As a dental therapist, I am able to do more for my patients, providing a higher level of care. Workforce development is essential in creating new pathways to grow a diverse workforce, which is why I'm excited to be part of this very important conversation today. I would now like to welcome Northwest Regional Primary Care Association CEO, Bruce Gray. Bruce brings a rich background in community health at both the federal and regional level. He has spent his career in healthcare policy, including work in the Bureau of Primary Healthcare, and is truly committed to improving the health, wellness, and well-being of medically underserved populations across the Northwest. We are honored to be partnering with both Bruce and the Northwest Primary Care Association for this year's Healthcare Symposium. Welcome, Bruce.
Thanks, Yadira. And really, it's so exciting and inspiring to hear your story and your career growth at Virginia Garcia. So I think this is what really draws us all to working in community health, is where individuals from the community can find opportunities to serve the community. So really, that's a very exciting story. As Yadira mentioned, I'm Bruce Gray, the CEO of the Northwest Regional Primary Care Association. We are absolutely delighted to be involved in and supporting this year's annual symposium, working both with the Virginia Garcia Foundation and the health center itself. So thank you, Gil and Stephanie. And I also want to echo Gil's expression of delight to have Dr. Padilla from the Bureau of Health Workforce joining us today. Dr. Padilla has really been a leader since he joined the Bureau of Health Workforce in developing more community-based programming and community-based workforce development out in the field. And so it's an honor to be involved in a webinar that brings Dr. Padilla here to the Northwest. And I also want to say on a personal level that I got to know Maria Laredo when she was still at Virginia Garcia as the COO, and was really inspired by Maria and her role and her just incredibly gentle but effective way at working within all the partners. She was really seen as a leader among COOs across the region. And so I think it's absolutely wonderful to see this new workforce development program through Virginia Garcia named in her honor. And I really find it a testimony to her over that 43 years, her really being committed to community health. So again, really an honor to be involved here and supporting this for NWRPCA. I look forward to hearing Dr. Padilla's remarks and the Q&A that follows. So thank you all very much for involving us.
Thank you again, Bruce, and the Northwest Regional Primary Care Association. So before I welcome our keynote, I want to remind all attendees that you can submit your questions in the chat. We will host a Q&A discussion after our main presentation. I now have the privilege of introducing our guest of honor today, Dr. Luis Padilla. Dr. Padilla is the Associate Administrator for the Health Workforce at the Health Resources and Services Administration, also known as HRSA. Dr. Padilla was appointed Associate Administrator for the Bureau of Health Workforce in May of 2016. He also serves as Director of the National Health Service Corps, the Bureau of Health Workforce's largest program with the field strength of approximately 13,900 clinicians nationwide. Prior to joining BHW, Dr. Padilla was Senior Health Policy Advisor to the CEO of Unity Healthcare in Washington, D.C., a federally qualified health center network with over 100,000 patients. A committed advocate for the underserved, Dr. Padilla is a former NHSC scholar who completed his service at Unity's Upper Cardoza Health Center, where he also served as its medical director. He served on the National Advisory Council of the NHSC from 2007 to 2010. Welcome, Dr. Padilla.
Thank you, David, and thank you for that kind introduction. It's a pleasure to be with all of you today. And thank you so much for the invitation to be a part of this webinar. Thank you for being allowing me to be a part of your conference. And I love the focus on rebuilding the workforce, and certainly we have a lot of rebuilding to do. So I appreciate the invitation to speak. Let me share my screen here so I could get started with my slides and hope that you all can see them well. I'm assuming you can at this point. Okay, thank you. All right, so just to begin, I want to outline for you what our workforce challenges are. And I don't think that this is going to come as a big surprise to any of you. And I hope it won't bring you too far down on a Wednesday morning there on the West Coast. But it's important to set that context of what we're facing right now in terms of workforce development across the country, particularly in rural and underserved areas. Share with you a little bit about what the Bureau is doing to address the needs currently across the country. Share with you our emphasis on community-based training, as Bruce so kindly said. We really have been focused on that in the last several years, being more intentional about leveraging our funding opportunities to support more community-based training. Talk a little bit about some key grant programs, some of which you might be very interested in, some that are open and some that are closed, but as these come up for recompetition, they could become important levers for you. And then talk about our loan repayment and scholarship programs, an important part of what we do to incentivize and recruit and retain clinicians, qualified clinicians in rural and underserved areas, and then just share with you some tools and resources. And I think we'll have ample opportunity for some questions afterwards. So as I mentioned, the grim reality is that COVID really laid bare a lot of the vulnerabilities, not only in health workforce development, but also in healthcare delivery. And the effects of COVID are going to be felt for years to come, and we're already feeling them. With a recent survey or a recent study showing that 49, almost 50% of clinicians who were surveyed here in this recent study in 2023 indicated an overall burn rate of almost 50%, with an intention to leave their careers at almost 29%. And as we all know, the intention to leave and the burnout rate increases as the workload demands increase. And this study showed that as the workload increased, there was a 2 and almost 3 times higher rate of burnout occurring. And at the risk of leaving, almost a doubling of that rate as the workload and demands on our clinicians increase. So certainly this is not something that is solely a part of COVID. This existed before COVID, but the additional pressures on all levels and all sectors of our health workforce have really created a unique situation for us to tackle. So as we look at what we see in terms of, sorry, I may have been behind on the slide here. These are the statistics from that study. I apologize. I'm off here. As we look at that backdrop, we also look at some of the projections that we have for our key workforce areas. And in terms of primary care, we're projecting a shortage of over 35,000 FTEs, in behavioral health over 15,000 FTEs, and in maternal health over 5,700 FTEs of maternal health providers, and in oral health over 1,300 FTEs in terms of shortages. Now, the data that I'm showing right here is reflective of what we know right now prior to COVID, and also in each of these areas, what we know for the first year of the pandemic. So we now have, because we've gotten some data from the census study that we use, the overall census, and some other studies that were released this past year. We now have a little bit of a picture about what happened in the first year. And subsequently, we're going to incorporate every year of the pandemic going forward into these projections. But so use these with caution, if you will. But it is showing us what the pandemic is doing in terms of our overall needs and the adequacy of the infrastructure to train and produce more providers. So if we look at nursing, and this is certainly one of the hardest hit areas, there's a bit of a variance. The hardest hit were registered nurses, and our projections are showing an overall decrease by 2025, a decrease by 2030, but then a slight increase by 2035. Again, all this is subject to change, flux as the dynamics change across the country. But right now, what we're projecting here is a pretty significant shortage of nurses in the next couple of years, and certainly up to 2030. Same with licensed professional nurses, licensed practical nurses, a shortage all the way up to 2035 of over 141,000 FTEs of LPNs. In nurse practitioners, before COVID, we were showing an oversupply of nurse practitioners. We continue to see that in the short term and in the near term. But that doesn't mean that there isn't a need of nurse practitioners in various parts of the country. And we certainly continue to see that maldistribution of this important segment of the nursing profession and clinical providers, where we see in particular areas a significant shortage of nurse practitioners. By health profession shortage area, which we designate across the country, just to give you an overall sort of accounting of HPSAs across the country, when you tally it up, we have over 20,000 HPSAs, 21,000 HPSAs across the country. When we look at your area, your geographical area in terms of Alaska, Idaho, Oregon, Washington, Alaska ranks third in the country in terms of overall number of HPSAs, health profession shortage areas in the country. Oregon is up there as well with this overall number, but you could see here significant health profession shortage areas in each of the designations that we produce. Again, this shouldn't come as a surprise to you. I think you live it each day. So what are we doing in terms of addressing that overall need and the context in which we're in right now? We continue to look at the continuum of workforce development from these three areas. Education, how are we improving the capacity to educate more students and incentivizing more younger students going into health professions and allied professions? Training, focusing on increasing the availability of our opportunities to train more clinicians, not only in health professions, but in other areas that are critically needed as well. And ultimately having them serve in rural and underserved areas, and through our significant programs, loan and scholarship programs, again, incentivizing, assisting organizations in their ability to recruit and retain a workforce. So through this continuum, we lever these aims. And as I said, the number one thing for us right now that we're faced with is increasing the supply, particularly in rural and underserved areas, especially for those disciplines that I just characterized as having significant shortages in the next few years to come. Improving that distribution of the workforce. But it's not enough to just put bodies in geographical areas. We have to make sure that we're advancing health equity, that we're also promoting resiliency among the workforce and those that we support through our training dollars, and that we continue to amplify our overall impact through the currently 50 workforce programs that the Bureau of Health Workforce here at HRSA is currently administering. We've been fortunate that our budget in the last few years has increased, certainly from 2019. This large infusion of the American Rescue Plan of $1.55 billion doubled our annual budget, which we broke out in 21 and 22. But we're well on our way to expending all of that $1.55 billion at the end of this fiscal year. And that's resulted in our ability to create new programs to support resiliency among healthcare workers and students and nurses. It's allowed us to expand the Teaching Health Center GME program I'll talk a little bit about later on. It's allowed us a record number of National Service Corps clinicians in the field, a record number of Nurse Corps clinicians in the field. It allowed us to supplement our state loan repayment program to the tune of $100 million for the next several years. It allowed us to increase our support of much needed professionals in behavioral health and mental health to the tune of $100 million. And it allowed us to create the largest investment that this Bureau has ever made in community health workers, in excess of $240 million to support the upskilling and training of new community health workers. So certainly that infusion of dollars has gone a long way. And I just commend every opportunity I can, our team that has been so diligently obligating all those funds, making all those awards, developing new programs. They've just done such a tremendous job. So as we look at our funding opportunities, we continue to focus on these drivers for success, those that we think are rooted in evidence, those that we think have worked as models of training that will support a health workforce in the future to deliver high quality, culturally competent care. Principal among them is recruiting students from communities that we ultimately want them to serve, having them look like as much as possible and speak the language of the communities we want them to serve. Training students in rural and underserved communities, supporting and enhancing the capacity of community-based organizations to do more education and training and support our programs, and then leveraging our loan and scholarship programs. We've come a long way from the days even when I was part of the National Service Corps. You'd be surprised to know that we currently have 7 programs and another one coming online this June under the umbrella of the National Service Corps. That will be 8 programs under that overall umbrella. And that's certainly more than I experienced when I was a member of the Corps. We continue to integrate behavioral health and public health into primary care. Those key services, particularly now in the areas of behavioral health, are much needed, and we want to continue to lever our funding to integrate those key services. So I want to brag a little bit because I think these cross-cutting measures really demonstrate what the agency and this Bureau has been able to do in terms of supporting workforce development in rural and underserved areas. I'm going to start from the bottom here. 25% of clinical sites that are in community-based settings. This is a significant advancement from several years ago, where we have more of our clinical training sites, and now we have mapped them all. They're available to you. Everybody on this call can go to our website, our HRSA Data Warehouse, and look at our mapper that delineates out all of the clinical training sites for the Bureau. We have tens of thousands of clinical training sites across the country. And I think it's important for us to keep monitoring this percentage and increasing this percentage. The percentage of graduates and alumni that are employed in underserved areas at 59%. This is a new measure, cross-cutting measure. This is a key indicator for us because at the end of the day, we want to make sure that our graduates, alumni, those that we supported through our various opportunities are employed in providing key services in areas of greatest need. 50% of program completers, graduates, represent underrepresented minorities and or come from disadvantaged backgrounds. This is key to addressing health equity. As I said before, it's not enough to put bodies in geographical areas. They need to reflect the communities that we ultimately want them to serve. 51% of our trainees are trained in medically underserved communities. This is beyond the community-based settings. This is inclusive of all of our training environments. We want more of our students to be trained in medically underserved communities. And 77% of those clinical training sites provided interprofessional training or individuals enrolled in primary care training programs. Again, exposing our students, trainees to primary care, interprofessional, interdisciplinary. How you're trained is likely how you're going to practice. So in doing this, one of the key components is partnerships, and all of you are part of that, that partnership rubric, if you will. We understand that we support academic institutions through our various programs. That is going to be the case for the foreseeable future. But we understand that making the linkages between academic programs that we support and community-based sites is important. Those partnerships between community health centers, academic institutions, and I know that in your region, whether it's in Washington, Oregon, Alaska, you're doing this already. And I see it. And I see the effects of those academic and community-based partnerships in training your current and future workforce. But we want to make sure that we, within our funding opportunities, have a more diverse applicant pool. It's important for us to go beyond the traditional academic institutions that we've supported to make sure that we're addressing, reaching out, and making it as easy as possible for minority serving institutions, community colleges, state universities and colleges who have a shared mission in not only diversifying the health workforce, but making sure that their graduates are going in areas of high need, that we're reaching out to them and we're expanding our opportunity to include them in as awardees in our overall programs. But this requires all of these community-based organizations, whether they're FQHCs, rural health clinics, or tribal urban Indian centers, to partner with these academic institutions. I don't think any one side of this equation is going to get it done alone, and that's why we're so focused on facilitating, supporting, and expanding these key partnerships. So I'm going to keep on bragging because 63% increase in community-based training at FQHCs is significant. This is going to continue to be an area that we're going to be monitoring. We are leveraging every opportunity that we can to support the infrastructure within the FQHCs to do more education and training. As I've said before, the environments in which you're delivering care right now, in these settings, in those community-based settings as FQHCs, is ripe for quality training. And as I said, I think all of you are doing this now. I think you understand the benefits of doing that and the ability that you have to recruit these students if they're trained in your settings. So I think this is a very important measure for us to continue tracking. If we break that out by program, we'll see that the A&E, what we call our nursing, advanced nursing and education program, our nurse practitioner residency program, and I apologize for all the acronyms on the slide, has really had a significant increase, in part because of the funding opportunity that provided a preference for FQHCs to come in for this funding, has really accelerated our ability to have more of these residents trained in these clinical settings. But not just there, in our teaching health center GME program, we've seen that increase. In our primary care training and enhancements, which trains medical students, PAs, with an emphasis in rural and underserved training, has also seen an increase. And this last academic year, we've seen a doubling of the percentage of clinical training sites that support our behavioral health workforce expansion training program, our BWET program, I love the call. This program is key in producing more professionals, paraprofessionals, peer support counselors out in the field. That program alone is slated to address 40% of the behavioral health and mental health shortages in the country without any increases in funding. And certainly we're going to lever any additional increases in funding in that very, very important program. A little bit about our grant programs. First, with the Teaching Health Center GME, and I'd like to say for those that say a big thank you for those of you who are already working in the space that have these THC GME programs. It's just been a tremendous accomplishment now over 10 years, 2010 when this program was established. And since 2011, when it began to get funding, we've had over 2,000 primary care dentists, providers out into the field. These are clinicians who were trained in the community-based residency program. are very well steeped in the needs of underserved communities, and 65% of them go on to work in primary care. 74% of them are right now training in FQHCs through this program. And residents, as you know, provide care. They're licensed, they're supervised, they're licensed, they're seeing patients, and they're seeing patients at a significant rate, 7.9 million hours of patient care in medically underserved areas. So in 2023, we started out with 47 planning and development. Those that are going to, the funding opportunity is going to create more THC GME programs. Now we're going to be at 93. We are at 93. We just made those awards. Almost all of them, if not nearly over 95% of them, are FQHC, that 93. So a significant investment not only in primary care, but also in supporting the pipeline and primary care needs of FQHCs across the country. So the potential impact of the funding instability, in particular, the funding cliff that we have right now that we're going to be facing at the end of this fiscal year, we run the risk of having 867 of those residencies interrupted or terminated, those residency FTEs, if you will. Having a reduced number of training slots because of this instability. There has been and will continue to be a hesitancy of these programs to recruit for residents in this fall, if they don't see stable funding for the next academic year. So we run the risk of 72 and upwards of 72 of these programs ceasing operations with unstable funding. So we continue to work with Congress and our stakeholders to shed light on this really important program and the instability that it's facing this fiscal year. Our primary care training and enhancement program I mentioned earlier, its objective overall is to strengthen the primary care workforce, support through enhanced training in rural and underserved areas. It's currently at almost 50 million in appropriation, and it's really gone a long way of exposing medical students and PAs to rural and underserved areas. And we've really taken advantage of our authorities and our ability to target more exposure in rural areas, in particular in underserved areas over the years. And I couldn't be more delighted in the direction that this program is going in, encouraging more medical students and PA students to go into primary care. As you look at our overall primary care training and our health centers and partners, we've awarded 58.3 million through the PCTE program, and particularly through this program in residency training and mental behavioral health, and a key program that helps integrate mental health training into the training of primary care. This is a result of the Safer Communities Act funding that we put out just last year. And it's really going to go a long way through these 24 awards in integrating behavioral health and primary care in supporting these residents in that additional training. A little bit about our nurse practitioner residency model, because as I mentioned, this has been really an ideal model of training that has provided additional training for nurse practitioners in a community-based setting. You see here that we have 46 grantees, 487 trainees. In our nurse practitioner residency program, 39% are in clearly FQHCs that are seeing over 290,000 patients. In our other arm of our nurse practitioner residency programs, is we really have sort of two arms of this. Even though they're in academic nurse practitioner residency programs, we see that over 40% of them are partnering with FQHCs. So again, it's our emphasis that even in these academic supported programs, we want that community-based emphasis, and we want those community-based partners in our funding opportunities. Our oral health programs and health centers, our pre-doctoral training in general, pediatric public health dentistry does a significant job in preparing pre-doctoral students going into community-based primary care delivery sites and providing oral health, as does our postdoctoral training in general pediatric and public health dentistry. While you have to have a dental school as partner, we have FQHCs that take advantage of these partnerships and have trainings through these programs occur in their health centers. So as I mentioned earlier, we were fortunate that through the American Rescue Plan Act, we received 225 million. I said 225 million of that went directly to programs, 83 awards. A number of those were in community-based organizations, including a PCA, the Massachusetts Mass League, that received one of these awards. That is really aimed at upskilling and supporting the training of, and our target is 13,000 community health workers trained or upskilled in that 3-year period, leveraging on-the-job training, apprenticeship models, building those skill sets, principally around core public health competencies to make sure that they're as effective care team members as they can be in delivering community outreach, linkages to care, being those trusted providers and those trusted navigators, if you will, that we know community health workers and allied and paraprofessionals are. Our health careers pipeline programs, and I just wanted to map out for you sort of the steps that we see in these programs, gaining exposure to the health professions, making sure that our students, particularly in our HCOP program, graduate from high school. It's unlikely that you're going to go into a health professions program, certainly in medicine, nursing, or a PA if you haven't graduated high school. So we're really looking at these programs sequentially and saying, how are we supporting our students in high school? How are we supporting them applying to college? And then maintaining that support, even when they transition into their next step, earning that degree, pursuing additional training, and finding a position, which is ultimately the aim here of all these programs. So whether it's the Health Careers Opportunities Program that really spans the gamut, our Center of Excellence that starts out with that exposure and then getting additional training, or scholarships for disadvantaged students that help students support them and stay in their health professions training once they're in, or our area health education centers across the country that also span the gamut on all 5 of these steps. So really key programs that bolster our pipeline efforts and really work with our community-based partners, including FQHCs, in supporting that very important pipeline. A little bit more about the Health Careers Opportunities Program. It's currently open right now. The funding opportunity was released a couple of weeks ago. Please take a look at it. Health centers are eligible to come in, as are community colleges as well. We want to make sure that we get a good, diverse pool of applicants. We understand it's not a huge amount of money. It's 13.5 million, 21 grants. It's pretty competitive. We are certain that we're going to get a great more number of applicants, and we're going to have the ability to expand. But again, we're putting a lot of requirements in this funding opportunity to support clinical training opportunities, to support the strategic partnerships, which really are a requirement for our awardees as a part of receiving these funds. I want to say a little bit about our provider resiliency programs. As I mentioned earlier, the American Rescue Plan allowed us the ability to support 2 key programs here. It's been very effective. We haven't gotten the full impact of this program yet. It's only its first year, if you will, but already what we're seeing here is we have graduates that have completed some of this training and participants now, 52,000 participants and trainees that are already going through this program. I can't say enough about these programs and their ability and the awardees that we've funded to support not just the future, but also organizations, and looking at their culture of wellness. What can we do to support those organizations that receive funding to help them look at their culture of delivering care, how they're supporting their workforce, and making adjustments and promoting wellness within their organizations. I don't think I need to say too much about the National Service Corps. Celebrated its 50th anniversary last year. Record members both in the National Service Corps and Nurse Corps, and our STAR LRP program, our substance use treatment and recovery program that was propped up a couple of years ago. If you tally all that up, it's over 24,000 members currently among those 3 key programs. It's just been phenomenal what this infusion of dollars has done. Unfortunately, the National Service Corps is going over the same cliff this funding year, so we need Congress to act to maintain the levels of expansion that we're benefited from the last 2 years. But overall, our field strength had an increase of 103%. We see that clinicians that are HRSA-funded health centers are at 56%, and 34% of those clinicians are providing services in rural communities. So really an important part, as you all know, of retaining, recruiting, and providing quality care to the communities that you serve. When we look at the National Service Corps, Nurse Corps post-service retention. These are phenomenal numbers. After completing their service, 85% at 1 year at HIPSA, 2-year HIPSA retention is 86%. HIPSA retention for the last 9 years is 83%. We now have the ability, and we're tracking here 25,000 clinicians. And we were able to utilize the data that we had from 2012 all the way to 21, and that retention still holds. We understand that our use of the nurse of the NPI number is what we use here. It's not perfect, but it gives us a better picture than what we had before when we were leveraging surveys that only had at upwards of a 30% response rate. And when you look at those clinicians during that same period of time that are retained in communities, similar communities or underserved communities, it's at 88%. So that's a significant story, and that's a story we like to tell about these programs. Once they're there, they want to stay there, and they continue to stay in the communities where they've completed their obligations. So the National Service Corps and Nurse Corps, as it relates to your area, wanted to offer you this data. It's available now on our website. You can see your field strength. You can even see your retention, and you can see the applications that came into your state this last go around. So here we've broken it out by the 4 states. And again, we see very high levels of retention here in your states, which to us, just means you're doing what you need to do to keep clinicians in your communities and in the HIPSAs well after they complete their service. So we have the National Service Corps scholarship program that is opening. That is open now. It's going to close actually tomorrow. Our loan repayment program closed last night, and a lot of activity on our website. The Nurse Corps scholarship program is going to close May 4th. Please make the final push. I think we're in good shape in terms of our applications. We're on track to get about the same number of applications that we got last year in the midst of COVID. I think that really the issue this year is going to be we're not going to have the funding in 23 that we had in 22. So really the reality is that we likely won't be able to fund all of the eligible applicants given the amount of funding that we have. But still, encouraging you all with those clinicians who are in those competitive HIPSs, particularly in this fiscal environment right now, to apply if they haven't done so already. The National Service Corps, as I mentioned, the site application is opening soon, and this is an important time for sites that need to recruit, hire, retain clinicians to come in and renew their site eligibility for new sites to come in to be National Service Corps participants. And our Division of Regional Operations has been doing a yeoman's job of reaching out, recruiting more sites and facilitating sites that are renewing their eligibility to be National Service Corps and Nurse Corps sites. So I want to close with some tools and resources. I've shared a lot of the information that is coming out of these resources. And what I mentioned earlier, this BHW footprint mapper, it details every single one of our training sites, where our clinicians are. It overlays it with HIPSAs, shortage designations. You also can see where FQHC sites are as well, and lookalike sites as well. So we're going to continue to enhance our data tools. We've shared them now at NAC meetings, the last PNI, the CHI. We've shared it with our PCA colleagues as well. And we're going to continue to take the show on the road in terms of the tools, the data tools that we have that really are meant to put what we have in your hands to help your workforce efforts, demonstrate to you what your need is in your communities, facilitate your ability to come in for our funding, whether you're coming in as the principal organization on those funding opportunities, or your ability to partner with academic institutions that we might support. I just want to highlight for you some additional resources here, grants.gov. We're accelerating our grants technical assistance. We are launching a contract that's going to support, we've already launched it. It's going to support minority serving institutions, HBCUs, community colleges. We're going to have targeted technical assistance webinars, again, in an effort to hear from them, and support their needs in being successful applicants, being successful awardees, and thereby diversifying our applicant pool. Our ongoing engagement efforts are not going to stop. They're going to continue. And sites like yours, organizations like yours, are key partners and stakeholders with us. So we appreciate the ongoing engagement that we've already had with you. We want to have more, and we want to hear from all of you. What else can we do to improve your ability to do more education and training, recruit your clinicians, and retain your clinicians in your communities? And with that, I'll end, and I just want to thank you again for the privilege of being part of this webinar. And thank you so much for everything that you've done and continue to do for our communities. Thank you. And I hope everything was okay. I'll hand it back over to you.
Yeah, I'm here. Thanks. Thank you, Dr. Padilla. That was great to hear about all the different programs available for workforce development. We've been receiving a lot of great questions and are excited to get started with answering them. We'll try to answer as many as possible. And since I am the moderator today, I will start us off with our first question from me. Virginia Garcia has sites in multiple areas. We have urban and rural sites. So, however, because HPSA scores are assigned to the health center as a whole, our rural sites must use the HPSA score that is assigned to our more urban centers that are closer to the population center of Portland. Has HRSA considered modifying this approach to scoring HPSA to take into account health centers serving broad areas like ours?
Yes, and we understand that that is a longstanding issue, and we have looked at that. We're going to continue to look at that. I will say, though, and thank you so much for the question, that in some areas, for example, in organizations that are multi-site networks, there may be a benefit to the approach that we take, and in some areas, there may be some impediments like the one that you're raising right now. We have heard from other stakeholders that they appreciate that because it covers at the entity level in one HPSA all of their sites. But we understand for some networks this may not be suitable for them, so want to continue the dialogue and see what we can do. It's challenging, however, in particular when you have and I worked in a multi-site network, when you have one site that has a low HPSA and another site that has a high HPSA, when you may have need for those clinicians to go from site to site. And the way that we structure our contracts right now as a result of the way that we structure our approaches, when we provide that HPSA at the entity, that essentially allows that clinician to move anywhere within that network. So one of the risks might be if you have a HPSA in one site and a different HPSA in another, you may not be able to utilize that provider in a lower HPSA where they have to go to a higher HPSA, for example. Thank you for that question.
Yeah, thank you for that clarification. I myself know because I hop around from all of our dental clinics. We have 6 dental clinics, and sometimes I work in the more rural sites and sometimes I work in more urban areas. So that makes sense. Next question. So is there data about the percentage of qualified medical professionals who are immigrants joining the workforce?
Sorry, could you repeat that one for me?
Is there data about, and this is actually kind of a 2-part question, is there data about the percentages of qualified medical professionals who are immigrants joining the workforce?
Yeah, I'm not sure that there could be in some of the data sets that I'd have to get back to you on that. We use a variety of data sets from different, ideally national services. Oftentimes we'll get demographics within those data sets. So we might have that if it's reported by the individual. Even within some of our programs, we don't collect it at that level. We certainly have race and ethnicity data on the vast majority of our programs, but it may not be on sort of immigrant status or their cultural background, if you will, beyond their race and ethnicity.
Okay. And kind of a follow-up to that, what are the current efforts to reduce barriers for internationally trained health professionals and immigrants who may be interested in pursuing or continuing a healthcare career in the US?
Yeah, so some of our programs have restrictions in terms of citizenship and residency status in terms of being eligible. For example, the National Service Corps. Per our statute and regulations, you have to be a citizen or a permanent resident to take advantage of our programs. But there are other programs that allow even DACA recipients to be eligible for some of our fundings and institutions that are supporting those students as well. So it varies program by program. If specifically you're asking, if the question was asked related to our support of foreign medical graduates into medical professions, there is a path that they have to pursue to complete an eligible residency within the country. Because again, for some of our programs, you have to complete that to be licensed in the United States. Obviously, your people on the call may be familiar with the Conrad 30 program, the J1 visa program. We don't play a big role in that beyond making sure that those that are receiving those visas are going into health profession shortage areas. So in terms of what we're doing, we do what we can within our flexibilities, our authorities, to allow those that aren't citizens or permanent residents to be eligible for our programs.
Thank you for that. I actually, when I was in hygiene school, I found out about the loan repayment program. And at the time, I was not a US citizen. So I actually had to go and apply for citizenship. And I actually received it before my graduation. So I was able to apply for loan repayment. So. All right, so we have another question. What are the best practices for health centers to consider in developing partnerships with the community to create pathways to healthcare careers?
So, I want to follow up with you. I'll just share some of those best practices. We've learned a lot by having our regional workforce workshops. We just finished one yesterday for Region 6. And we're adapting those more to hear more of those successes, those models that we want to share. So I'd like to follow up with sharing some of that as we roll up those workshops, because I think there's a lot to the point of the question here that we can learn from other organizations in terms of what they're doing. That said, though, I would say that it starts with assessing who your partners. I think it could start with assessing who your academic partners are within your communities. And certainly, I think one of the major areas to look at that would help us and align with our efforts is those community colleges, those state organizations that have shared missions. I think it's important for community-based organizations to look for like-minded partners that have a shared mission. I'll give you an example of UC Davis that has spent decades now, over a decade, shoring up those partnerships, really being intentional in those community-based partnerships. And what they've been able to do in the time that they've been doing this is increase the number of underrepresented minorities enrolled into their medical school. I think they went from 10% to almost half of their enrollment now, because they partner with community-based organizations, they partner with Indian student groups, they partner with community colleges, those organizations that will identify promising students, partner with them in that shared vision and mission, and they've been really quite successful. So just one model that I'd like to just certainly provide more information after the webinar in terms of how to form those partnerships and with whom.
Thank you. Next question. Educational organizations are struggling to recruit and retain instructors for healthcare program, which leads to reduced class size, in particular for nursing. How could this potentially be supported at the federal level?
Yeah, well, it already is. We've already put out funding to support clinical. Administrator Johnson is really focused on the nursing workforce. And as we have identified those three areas, and this is a key area that you just mentioned, and thank you for this question, clinical and academic faculty and clinical precepting and space are three of the areas that we've identified as critical barriers to accelerating our ability to increase the number of of students enrolling. So the funding that we've already put out to support clinical and academic faculty in nursing in the president's budget, there's an additional request to support these efforts. So we're focused on those three areas, and wherever we have the ability and Congress gives us the ability through funds or authority, we want to continue to focus in on that. I think, sort of embedded in that question is how we can support community-based organizations in offsetting the cost and time that it takes for a clinician to be a clinical preceptor, because those clinical preceptors don't always come from these academic institutions. It certainly comes from community-based organizations who have to devote their time and their clinical expertise to support students. So in the past, we have provided preceptor coordinating support for our awardees to partner with community-based organizations to at least provide some of that logistical support. And we're looking for ways, again, and every opportunity that we engage in. I encourage anyone and I'm not advocating, but this issue also should be raised to other policymakers to say that that's a critical need that we have, and in leveraging any ability that we have to support the community-based organization to support training, education, and training, because that is, and we realize, a key impediment.
Yeah, thank you for that. I mean, I just in our own organization, I know that we would like to see more students, but again, it's hard on our clinicians to try and, do their job and see, patients, and then also have students. And so being able to help support that and help our clinicians be able to do that instructions with students, I think is huge, because I mean, the mentorship that they provide students, the inspiration that they provide them to, get into this work is amazing.
Yeah. And just to follow up on it, David, I never want to miss the opportunity to tout THC GME model and the nurse break. That's what that does. The money that we support, the money that we provide to support those residents is to support the salaries of the residents, but also faculty and faculty development. So, and the same with the nurse practitioner residency program, and the same with the addiction medicine fellowship program. So as we look towards expanding those programs, those are programs that do just that. Now, not every FQHC is going to be a THC GME or a nurse practitioner residency, although, that's my pipe dream. Those programs afford that infrastructure support.
Thank you. Next question. So as a dental therapist, I have a personal interest in this next one. Are there any plans on the horizon to support dental therapy at the federal level?
And we've done that as well, Yadira, and I think it's important to note that only 20 states, I believe, have scope of licensure for dental therapists, right?
Yeah.
Within their scope of licensure laws. So it's incumbent upon states to take a look at that, the needs of communities in terms of oral health. But what we've done is opened up the ability for our awardees through our state oral health program to provide training to dental therapists. Was not necessarily a popular move by some, but I think it's an important move on our part to address oral health needs across the country and making sure that access to appropriate oral care is delivered. And so that's at least one way that we're trying to promote access to oral care.
Great, thank you. Yeah, I couldn't agree with you more. So we have another question. Is there a theory as to why it seems fewer people are going into certification level healthcare careers, such as LPNs, compared to nurse practitioners, which require more education?
Yeah. Well, this has been a trend for years. And when we engage with our nursing colleagues in both academia and through associations, there has been a push to have higher training among nursing. We believe, and I think particularly right now, some of the data that I showed in terms of the impact on LPNs, RNs, demonstrates a need to continue to focus at entry level career positions. If you look at the demographics of nursing, the most diverse component of the nursing workforce is at the LPN RN level. So there's also an equity argument to be made that as you increase the requirements the scaling up of educational credentialing, there's an effect. And that effect is you will see less diversity. You certainly see that in nurse practitioner, you see that in APRNs. And so for us, we put out funding to support career laddering. If you look at our Nurse Corps scholarship program, dedicated in the last 2 years, $4 million for LPN scholarships. So a medical assistant who wants to go into nursing, whether it's an LPN program in a community college or an RN degree, can take advantage of our scholarships to do that. We did that set aside because we recognize the importance to continue to support that component of the nursing workforce.
Thank you.
Thank you.
For that answer. Let me see. So there has been, and actually, I think we're getting close to our last question here. So let me see. There have been a lot of investment in nurse practitioner residency programs at the federal level. Is there a plan to invest in residencies for all nurses as well?
I guess I'd have to clarify a little bit more what we mean by all nurses as well, because there's not even a requirement for residencies within nurse practitioner disciplines. They have moved quickly over the years to start up their own accrediting body. But as far as I understand, there's not a residency requirement at this time for any nursing program. That said, we offer advanced degree support. Our advanced nursing education, the entire line of that funding is dedicated to that. Our nurse anesthetist program, which produces more rural nurse anesthetists than any program in the country, supports nurse anesthetist training. So those that go beyond their training as nurse practitioners or advanced practice nurses can don't get that additional training. So I guess I would just like to hear more about what other nurse residency programs are being spoken of.
Okay. I'm not sure in particular which residency we can come back to that and see which other residencies. Okay, I don't think that would, okay. So let me see, here we go. Are there creative solutions and strategies that are being explored to stabilize the job market conditions that are continuing to the current healthcare workforce shortages?
Yeah, and that's a bit beyond my scope since we primarily work with the workforce development. But for those of you who are policy wonks, you may have seen our administrator, Carol Johnson, testify today, the Labor HHS Oversight Committee earlier last week with the ENC committee on the House. And this question came up. And while this is certainly not our space, we'll highlight this. There are certain things that we support through our program that we believe create that environment, interprofessional, multidisciplinary, making sure that we have a diverse enrollment of students entering into the schools, supporting through whatever healthcare delivery funding we have, supporting the environment in which clinicians and others work to make sure that that environment is conducive to longer term retention are all parts that we can do. But beyond that, the market forces and addressing other areas, for example, if the question is around staffing ratios, et cetera, that's a bit beyond our purview.
Thank you for that. And so we have our last question here. In the face of so much healthcare staff burnout, what are best practices to find and keep passionate and skilled preceptors in a low-staffed workforce setting?
Sorry, I was reading Gil's comment here on the nurse residency, so I missed your question because I couldn't.
Okay.
Apparently, I can't read and listen at the same time.
In the face of so much healthcare staff burnout, what are the best practices to find and keep passionate and skilled preceptors in a low-staffed workforce setting?
Boy, that's a toughie too. Again, I want to provide some resources around our health equity research centers that have been providing a lot of research and data on resiliency. Because I think while there's a lot of evidence at the individual level, sort of intervention, wellness programs, linkages to mental behavioral health services per provider, there aren't a lot in terms of what organizations can do. And this is why that funding that I mentioned earlier, where we're supporting organizations, as we learn more about what they're doing and their practices and the results, we want to share that. What we're seeing early on from some of them is making sure that those efforts that's perhaps started in a hospital setting that we're working, we see some of our awardees taking that and expanding it to community-based settings. Mass League is one notable one where they're taking what they've learned, models that were created in one environment, they want to expand and be more inclusive of their staff to take advantage. So our funding is key in helping organizations fund that kind of expansion and other new efforts as well. You know, overall, I would say you did, and I probably speak out of turn here, but when you have a complement of a care team that is not just professional focused, but also focused on those that support the care team, whether it's social workers, care workers, or community health workers, and even scribes, it goes a long way in creating and fostering that support that clinicians need in the demanding setting that they're asked to deliver care in. So I think anything that an organization can do to say, we're going to support you in this task that you're doing. So you're not up until 1 o'clock in the morning charting and thinking you're all alone, right? These things that sort of grind a clinician in particular, and don't spread the care responsibility and puts it only on a few. I think those things are precarious models long term. And maybe I'm speaking out of turn, but just my personal thoughts on that.
Oh, thank you for that. And so I was kidding. That wasn't our last question.
Okay.
We have one more question here, and it's from Bruce Gray. So let me just bring it up here. You find it. Oh, wait.
Somebody said, sorry, Laura says a perfect answer. I've never been accused of that. So thank you, Laura. Perfect answer. Thank you.
Okay.
Perfect answer.
And so this question is, what opportunities are there in working with CDC to develop more integrated team-based workforce models that address the social determinants of health and going upstream with health, wellness, and well-being? And how is HRSA pursuing these opportunities and partnering in general with CDC on such workforce issues and model evolution?
Yeah, thank you for that. So, you know, we have a long history of interprofessional training and education. I think, you know, there have been over the years some challenges there because, you know, supporting multiple schools and multiple disciplines in one setting has been challenging. But I'll tell you, we've seen through our various programs, because we put a lot of emphasis on interprofessional, we put a lot of emphasis on social determinants of health. And in many of our programs now, looking more at, I'll mention the HCOP program, looking more at the social determinants of education. We're putting more of that language in our funding opportunities. And specifically what I mean by that is, if you're going to put a student in a health professions environment and not recognize perhaps some of the challenges that they've had in their background that they bring when they enroll, and you're not addressing that, it's likely that they might not graduate, matriculate from that school. So more and more we're looking at, we started a great thing here, but how can we continue it? So I think the CDC partnership is a great one. The money that they put out for community-based training, we've been working with them on how do we complement what they've done. They put out, if they haven't put it all out, $3 billion through the ARP. That's a lot in terms of public health infrastructure needs, a lot of money going towards community-based organizations, and in a particular area, that funding looking at community health workers. So we're going to continue to partner with them on particularly around the public health integration piece. We started now for the first time ever, a jointly funded public health research workforce research center that's kicked off this year. We're excited about that partnership because again, it creates more ties with the CDC. And I think as we engage more and more with them on what they've done with their funding and how we might be able to complement, they're pretty significant investment in the workforce across the country.
And let me see, we have time. Okay, we do have time for another question. So how does HRSA select or pursue opportunities to advance equity?
So, I mean, we consider ourselves not shyly the agency of health equity. Our mission is to improve health equity, reduce health disparity. So it's ingrained on everything that we do, whether it's in the health center program, the Ryan White program, our maternal child health program, and then certainly in the Bureau of Health Workforce. So this isn't new to us. So what specifically are we doing? One, it starts with making sure, and our administrator has really led the charge in how can we make these applications simpler, streamline them? These are grants. How can we reduce the burden on those that want to come in and don't always have the infrastructure or capacity to come in? So that's number one, shortening them, making them more plain language. The other, as I mentioned earlier, is more technical assistance to those organizations that are serving those communities and already enrolling students that they hope will go into health professions, minority serving institutions, HBCUs, community colleges, as I said, state universities as well. So we're increasing our efforts to support them. And we're going to continue to do so because we think it's an important aspect of what we do. We need to, if we're asking the field to diversify in terms of health professions, we need to diversify our applicant pool and our awardee pool as well.
Great. And I guess final question for me, where with so many grants and so many programs, is there a resource that someone can go to kind of choose which one fits them best? Because I mean, you went through a lot of programs.
Oh, I did.
So,
I know.
So
And
sometimes that, yeah, it could be overwhelming.
Yeah,
So
it
if there was
is.
one resource, what would it be?
Yeah. Okay. I'm going to start you off with our website. And the opportunities that we list there. We recognize that when you go there, we often describe these programs in terms of the funding opportunity. We're trying to address that, but really it starts there. If you're an FQHC, you may have already participated with your PCAs on our workforce workshops. We're going to conclude all of the regions by this year, by the end of this year, early next year. So that at least gives us an opportunity to hit all the regions. We want to take a step back and say, okay, what's the next step for that? Do we need to develop a clearer sort of mapping, if you will, of our programs to allow people to come in and to at least know what our programs do and how they might be eligible? So we want to work on that. We know we're not there. There are a lot of programs, a lot of requirements. I can give you the acronym soup here, so it becomes pretty dizzying. So we want to continue to work on that. So thoughts you have on that, please send them my way.
Okay. Well, thank you so much for your time and your wisdom on this important topic. And before we end today's event, I would now like to bring to the screen Executive Director of the Virginia Garcia Memorial Foundation, Stephanie Caballero. Our foundation team has played an instrumental role in raising critical dollars to make our workforce development programs at Virginia Garcia a reality. Welcome, Stephanie.
Thank you, Yadira, and thank you for leading us through this wonderful presentation and event today. To everyone who is here, thank you for joining us. What a rich discussion and great ideas to ponder of. Truly grateful that you've chosen to be here with us this afternoon or morning, depending on when we started and where you're at. Good afternoon, everyone. My name is Stephanie Caballero, and I'm the Executive Director of the Virginia Garcia Memorial Foundation. It has been a true pleasure to be here with all of you today. Virginia Garcia was born from adversity and founded on the belief that everyone, regardless of their circumstances, deserves equal access to high-quality, culturally appropriate healthcare. We have spent the past 48 years ensuring that our patients and others in the community know they can trust Virginia Garcia to deliver the care they need. The work many of us here this afternoon carry out every single day has been greatly impacted by the staffing challenges we have experienced these past few years, but continue to experience today. This is a complex issue, and we do not expect to walk away with the solution today. We know that there's no solution in the short term. Restoring and rebuilding our most valuable asset as a healthcare system, our workforce, is going to take time and careful consideration. It will take innovation and critical funding, which we heard about today, to establish and offer creative opportunities. We invite you to make a gift to support our workforce development programs to not only help us continue to bring critical services to our patients, but to also support a new generation of diverse healthcare providers. We heard here today, many of you asked wonderful questions about that. You can support our development efforts here at Virginia Garcia and that new generation by making a gift today. You can scan the QR code on the screen to support these programs. Virginia Garcia will continue to innovate and develop new ways to ensure our current and new staff have the opportunity to grow within our organization. We hope that today has given you helpful information and ideas on what is possible to help you and your organization or company address these challenges from within. The communities we serve are at the forefront of all that we do. Let's remember that and commit to continue working together to create a sustainable and innovative listing of development programs. We heard again many of them today, but the work here continues. Before we part today, I want to give special thanks to Yadira Martinez, our moderator, for doing a fantastic job. Yadira, as Gil mentioned, we admire you and are grateful for the many ways you support, breathe, and live the mission of Virginia Garcia. Thank you. I also want to thank Dr. Luis Padilla for taking time from his busy schedule to join us here and really share insightful information and important program and funding opportunities with us. That was truly an engaging discussion. Thank you. And I want to take the time to also thank Northwest Regional Primary Care Association and Bruce for his leadership and for their tremendous partnership in getting so many of you here today. It truly has been wonderful to see many participants from not just the Northwest region, but from across the nation. Thank you for taking the time. And last but not least, I do want to take special time to thank our amazing event sponsors because their support truly makes this event possible and accessible to so many of you free of charge. To our annual partners, A2C Wineworks, Care Oregon, Kaiser Permanente, Legacy Health, McDonald's Air and Insurance, Oregon Health and Science University, and One Digital. To our friend sponsors, you can read on the screen, and also to our ally sponsors. Thank you all for making today possible. And big thanks to all of you for joining us. Be well.